Hello again, I'm Dr. Hung Vu and our show is America's Healthcare Crisis. The title for our program tonight is The Quality Issue in Dermatology. This is part of a series of productions when I will have the opportunity to interview the experts in their field of practice, and tonight we talk about dermatology. During the past productions, we had the opportunity to interview internists and pediatricians, and tonight we'll approach the field of dermatology, and I'd like to introduce our speakers. Dr. Ross Bright, how are you, Dr. Bright?
Very well. Pleasure to be here.
Thank you for being here with us tonight. It's good to see you. Dr. Bright is a dermatologist who has been in practice for a very long time in Los Altos. He was a graduate from the School of Medicine of Stanford and also received his postgraduate training in dermatology there. And at the present time, he is involved in some aspect of research in dermatology, and he's also an associate dean at Stanford University, and it's an honor to have him here with us tonight.
Thank you.
Thank you. Dr. James Arnold is our second speaker. Dr. Arnold was a graduate from the School of Medicine of Maryland and had his postgraduate training in dermatology at Stanford University and has been in practice of dermatology in San Jose for a number of years. And for the last 3 years or so, he specializes in hair transplant. Is that right?
Yes.
Okay. Maybe you can introduce yourself to the audience so that we can get to know you a little bit better. Dr. Bright.
Well, I grew up in the area. Went to school at Stanford. Didn't wander very far. Undergraduate school, medical school. Did my internship down at Valley Medical Center in San Jose, and then went back to Stanford for residency. Stayed on there for a couple of years in the academic aspect of it, and then went into practice in the Mountain View, Los Altos area at El Camino Hospital for 30 years. And 2 years ago I left practice and went into this research unit where I'm working now in Palo Alto, which is basically a skin biology unit studying a variety of skin diseases and most importantly psoriasis.
And at one time you were also involved in a news production for Channel 11, is that it?
I worked at Channel 11 for 6 years, from 1986 through 1992, basically doing short subjects on a variety of medical topics on the evening news. This was something that was, I guess the TV bug bit me, and once I had a little bit of it under my belt, I found it very satisfying, very enjoying, but very time-consuming.
Dr. Arnold?
Well, I grew up on the East Coast, and then after medical school, it's a time when the Vietnam War was going on, and we had to either make some sort of arrangements or run the risk of being drafted, and I elected to join the Public Health Service and worked on an Indian reservation for 2 years, which moved me out west, and after that decided to go into dermatology and applied to different schools in California and ended up at Stanford. Moving west rather than growing up out here like so many people.
Yeah. What made you decide to become a doctor and dermatology?
Boy, why did I decide to become a doctor? I'm not really sure. It was something that I can recall wanting to do since day one. I don't know where the influence came from, and I had no one in my family who was a physician. I had a granddad who was a dentist, but just one of those things that I had always aspired towards. In terms of why going into dermatology, I had very excellent training as an undergraduate at Stanford. The professor and chairman of the department, Dr. Farber, was a superb clinician and a very excellent teacher. When I was in the military, I nearly went into obstetrics, I should say, preface this, and then I backed out of the obstetrical residency at the last minute and joined the Army as we were all required to do in those days. And ended up working a great deal alongside of a dermatologist at Fort Sill, Oklahoma. And the combination of these two influences, I think, are what required me to get into dermatology. It's a specialty wherein you can deal with patients both on the medical aspect of their problems, and also there was a fair amount of surgery involved. So it blended a lot of areas of medicine, which I enjoyed.
So it was almost like a fateful exposure to a good role model, you would say, Dr. Farber?
I think so. I think he certainly played a major role, a major influence in my decision making.
Dr. Arnold?
Yeah, I actually had a similar experience. Although in college I was really interested in two careers. engineering, and I actually started my studies, undergraduate studies in engineering, and then switched to medicine in my junior year. So it was a difficult choice between the two, but I thought it'd be better to be a physician and frustrated at engineering rather than to be an engineer and frustrated at not being a physician. I'm not sure that's true. But
So you left private practice about 5 years ago?
2 years ago.
2 years ago. So give us a sort of a mental picture of what it was like to be in practice in Los Altos in dermatology. What are the common problems that you've been seeing all these years?
Well, I think the problems that are common to dermatology are not common to any specific area. The majority of the patients that we see in dermatology fall into just several disease categories. What we call eczema, which includes allergies to a variety of things that you touch, come in contact with. We see a lot of kids with warts and adults with warts. We see a fair amount of skin cancer. We see those changes on the sun-exposed surfaces which lead to skin cancer called keratoses. See people with psoriasis, people with seborrheic dermatitis, so-called dandruff dermatitis. We see fungus infections and bacterial infections. And probably of those 6 or 8 or 10 diseases that I just mentioned, this would account for, I would guess, probably 90% of what we see. Then beyond that, I think in the dermatology textbooks, there's some 1,500 diseases that are defined, and the other 10% would make up from those 1,500 disorders that are rare and uncommonly seen in a day-to-day practice.
Yeah, that's exactly what I thought too. That's very interesting. You agree with that? Most of the cases you saw in practice would belong to those?
Yeah, certainly there's a certain group of diseases, like Ross says, that make up the majority of the patients. Although there's quite a bit of variation within that group. I mean, some patients may have an allergy reaction that's quite severe, and others not so severe. Or some may have a condition involving a small area of the skin, and others, a widespread area. Often they vary just because they show up at different times of life, even though they're the same condition. Great variations in the same condition from person to person, one patient to the next. Sometimes in slight variation in ethnic groups, certain diseases be more prevalent or more troublesome to people in certain categories.
So you think that if we concentrate our energy and resources in polishing the management of those 10 problems you're talking about and train the primary care providers, you would reduce the cost of practicing dermatology?
That's a tough one. Certainly, primary care physicians can be properly trained to deal with the majority of dermatologic problems. There's little doubt in my mind about that, and we're, in a sense, being forced in that direction because of so-called managed care, where direct access to the specialist is disallowed by most insurance carriers. So I suppose you could say, yes, in some instances this would be a money-saving device, but where this falls short of the mark is oftentimes there are subtleties in skin diseases which can be missed by the less than practiced eye. And this is certainly true. Primary care physicians have a tremendous load on their shoulders at this stage. The managed care people want them to be experts in diseases of the eye and in neurology and dermatology and cardiology and so forth. And it's virtually impossible for anyone to know all the subtleties and intricacies of a specialty. Sure, the vast majority of problems can be adequately handled. Case in point, fungus infections can be extremely difficult to diagnose, very subtle, and if improperly treated or if the diagnosis is not properly made, a great deal of time in terms of office visits and a great deal of expense in terms of medications that are purchased and used, which may be totally ineffectual for the problem, in fact may prolong the problem. Whereas referral to the dermatologist, it's a good bet that that fungus infection will be picked up on the first visit. So you'll end up with one visit, one prescription, as opposed to 5 or 6 visits and half a dozen prescriptions. There, obviously, the money-saving aspect of it would be to see the primary care physician first. So it's going to be interesting to see how this plays out, how all the cost analyses are determined.
Well, a very
down the road.
important job for the primary care provider is know how or when to refer.
Absolutely.
So that's the point well taken, because I feel that it's true in any specialty. Obviously, we cannot have the expertise of someone who focus all the attention on one area of the body, be it the skin or the eye. But I have been in primary care for many years, and we do the screening job, and up to a certain point when you don't feel comfortable doing certain things anymore, we refer. And that's the key to cost effectiveness in medical care. But tell us about some of the situations that you encountered that were more serious, melanoma maybe, and how you handle it.
Melanoma is certainly something that I've been at this for about 35 years, and certainly melanoma is more common. This is well recognized throughout the country. The incidence of melanoma is increasing rather dramatically. I believe it's increasing more rapidly, the incidence of it, than any other cancer. And I've always felt that melanoma is a surgical disease, and the minute that I've recognized a melanoma, that I am absolutely certain in my mind, I have not treated that person but have sent them directly to the surgeon for a much more widespread excision than I would be comfortable doing with my surgical skills. I've taken off a number of tumors where it's questionable, and then once the pathologist makes the diagnosis, then again I would refer these on to the appropriate individuals. Melanoma it's common, but yet not so common that everybody, I think, has a handle on necessarily treating it properly, and I've always referred my patients with melanoma to a melanoma specialist, of whom there are several around in the area now. That's certainly one very serious illness. Leprosy is one of my favorites. We think of leprosy as being something that's going to occur in the tropics and something we're not going to see around here. Although at Stanford we were all very well trained in leprosy at the Public Health Service Hospital, which used to exist in San Francisco before government cutbacks closed it down. We were all indoctrinated into the recognition of leprosy, and in the years that I practiced, I diagnosed 4 lepers in my practice, 2 of whom had never been outside of California. They were not from the Philippines or the Sinaloa area of Mexico and so forth. Probably the most serious of the other problems that we would see would be very widespread psoriasis, which can be a devastating disease and very difficult to control. And some of the more severe skin cancers that would be a real therapeutic challenge to clear. And then certainly severe drug eruptions. One of the problems of medicine are reactions to medications, and certainly these are commonly manifest by very, very serious skin eruptions. Off the top of my head, those are probably amongst the most serious problems that I would have encountered.
I see. Well, what is the average number of hours you spend in practice on the average, during a busy time of your practice? How many hours do you spend practicing?
When I was in practice, it was less than a 40-hour week, but it would average between 32 and maybe 38 hours a week. But there were hours that were very intense. I think one of the most difficult jobs that someone can have is dealing directly one-on-one with individuals. And dermatology, by and large, lends itself to seeing fairly large numbers of patients per day. Maybe 40 or 50 patients is not unusual in a dermatology practice. And to have that many, serious encounters with people during the course of a day is can be mentally exhausting.
So you spend a few hours, say, like internist or neonatologist, but you see a larger number of patients, is that it?
Yeah, by and large. I mean, some of the diseases are actually very easy to diagnose. I mean, there's been some studies that show that about 80% of the skin conditions that are seen for the first time by the dermatologist can be diagnosed in the blink of an eye. I mean, some of those are obvious, like you know, a wart or certain rashes that we just look at it and immediately know what it is. So that category, the time spent in diagnosis is not very long. But then there's other conditions where you know, you have to do some tests. Traditionally, if you do, you know, the typical test that we use, which is a skin biopsy, you can get a microscopic view of what's going on. You can increase the diagnosis rate from 80% to 90%. And then you can do other tests like laboratory tests, blood tests, or cultures of the skin for fungus or bacteria and such. That raises the level up to about 95%. But there's about 5% that no matter what you do, you're really not quite sure what they have or what's going on. Either they as an individual have a common disease that just manifests itself a little differently than is typical, or it's just something that's it doesn't fit the pattern of other skin diseases.
So you're talking that you're saying that 90 or 95% of the clinical presentations you saw in practice had a self-limited course and went away, or I mean,
no, not at all. I mean, some of them. This was just the ability to make the diagnosis.
Oh, I see.
And if there's one thing I've learned after years in practice, is the singular most important thing that you can give to a patient is the right diagnosis.
Okay.
Because once you have the diagnosis, the rest of it falls in place. You know, the treatment and answering their questions as to, you know, what do they have and why do they have it, and is it related to cancer, or is it related to internal disease, or how long will it last, or what should I do? All the rest of it's easy. It's making the diagnosis that's difficult.
Yeah.
And that's my criticism of you know, primary care doctors, not the ones that are willing to admit that they don't have the diagnosis, but the ones that truly do not have a diagnosis but go through these regimens that Ross suggested or indicated often occurs, where they think it might be an allergy, so they'll treat for an allergy, and say if it doesn't get better, come back in a couple of weeks, and then they'll treat for a fungus, and if it doesn't get better, they come back and they treat it for something else. They've never made the diagnosis. And I truly believe that's the one thing that the physician, whether he's a dermatologist or not a dermatologist, I mean, he owes that to the patient to make the right diagnosis.
From my standpoint of being in primary care, I would say this, is that the great majority of patients who come to us come with an undifferentiated kind of symptomatology, be it a rash or whatever. You see them the first time, so we don't have enough information to establish a diagnosis. And then, you know, a few times afterwards, the time is very relevant in terms of unraveling things. And after a certain period of time, when it becomes obvious, the specialist has no difficulty in diagnosing it. Am I communicating?
You're communicating, but I'm not agreeing.
You don't agree?
No, I think in almost every instance, the patient has what you traditionally expect in medicine. That the patient has one disease, and it has a certain appearance at the onset, and has a certain appearance midway in the course, or when it's well established. And it's those subtle little, you know, changes at the onset that allows a dermatologist in a blink of an eye to make the diagnosis.
Yeah, I would certainly agree with Jim on that. To elaborate on your point, yes, in some instances, over a period of time, a disease will evolve.
Yeah.
Take the leprosy we were talking about a bit ago. At its very onset, it could be so subtle that no one's going to make the diagnosis.
Right.
You won't make the diagnosis unless you think of the diagnosis, and you're probably not going to think about it if it's just a wee, tiny, insignificant little spot on the back of the hand. And that, over the course of time, may evolve into something that anybody at a given time will recognize. But that's usually not the case with skin problems. They are not all that mysterious in their behavior. They follow a certain pattern, and the expertise that one develops with a lot of study during residency and then X number of years under his or her belt looking at skin diseases. You get a whole lot. It's like hitting golf balls. The more you hit, the better you get. And the more skins you look at, the better you get. And as Jim was saying, the majority of the time, you can recognize the disease across the room in the first 30 seconds they come in. Because dermatology being the skin's a visible organ, so it's disease processes are for the most part totally visible. And this is where the real skill of the dermatologist comes in, as Jim said, making an early and hopefully appropriate, correct diagnosis.
Yeah. Now, tell me, beside the visual diagnosis, what are the other tools that you commonly use in practice to diagnose a condition?
Well, generally, I would say, as Jim said, probably 80% of the time, you don't need much else beyond the naked eye. If there's something that you are uncertain of, and primarily here you're talking about, is it benign, is it malignant, is it skin cancer, or just something that's thinking about becoming a skin cancer, and then the biopsy becomes a critical tool. Or in some disorders, diseases of the scalp, for instance, there's a whole host of things that something could be that looks red and flaky and scaly in the scalp, and here taking a piece of skin, the so-called biopsy, can differentiate these because the patterns under the microscope are quite different. We use cultures to determine whether blisters on the skin could be a virus infection, the herpes virus, for instance. We use cultures to determine the type of bacteria that may be infecting a wound. We use cultures to determine if it's a fungus, and if so, what is the species of fungus that's causing a child's ringworm and so forth. We take scrapings of the skin to diagnose the itch mite disease, scabies. We will remove organisms when making a diagnosis of head or body or pubic lice in an individual. There are special types of lamps that we will use to fluoresce the skin in different areas, which can show unusual and subtle infections with fungi and with bacterial organisms and the like. I think these are the main tools that come to my mind.
Just touching back for a moment on the visual aspect. People find it hard to believe how precise the vision can be. But if you think about it, you can be walking down the street and have someone who's close to you, like your grandmother or someone, half a block away crossing the street, and you glance and you say, "Oh, there's my grandmother," crossing the street. There's there's a visual identification. On the other hand, if you try to teach that to someone else, you tell them that my grandmother's 5'6" and she has gray hair and she likes to wear her old brown shoes. It's highly unlikely that someone would be able to identify that person. And by seeing skin conditions day after day and time after time, they become like old friends almost. You can you glance at them and you can recognize psoriasis from eczema, from allergy, from lichen planus, and I find those things are commonly put in one bag by.
Now, I guess dermatology may be a little bit different from other specialties in terms of coming from an undifferentiated to a more well-defined pattern. But I just think about the fact that I am capable of recognizing many of the common conditions that you're talking about. And it seems to me like it would not be so, I don't know why it's so difficult to train the majority of the primary care providers to recognize those common conditions.
Well, I think it's like teaching a child the multiplication tables. You can show them the pictures up on the board that the 2 times 2 is 4, but until the youngster goes home and does it repeatedly over and over and over and over again, it may not sink in. They may not gain a total and complete understanding of the multiplication tables and how they work and what they mean and so forth. And I think it's a matter of getting back to the golf balls. I can go to a pro and take a couple of lessons, and I would be taught the proper technique, but unless I go out and hit 10,000 golf balls, I'm probably never going to hit the ball worth a darn. And I think that's where short-term education in short bursts falls short of the mark. It's got to be repetitive, and this is why residencies in specialties are relatively long.
I see. We're talking about 10, I mean, diagnosis, though. It's just kind of hard for me to imagine how difficult it is to train people to recognize 10 visual diagnoses.
But let's go beyond just the recognition. Then comes the treatment aspect.
Right.
One that I think I left out of my list of 10 was acne, and for pity's sake, that's one that's probably the lion's share of an awful lot of practices. And acne is not a simple disease. Acne in its simplest form, sure, the youngster can treat by themselves without necessarily a physician getting involved in the act, or the mild acnes. But when you get into the more difficult acnes, or those that have run the long gamut, those that have failed to respond, their expertise and experience comes in terms of defining the problem and what is best done for that individual.
Okay, we have to wrap it up now because we're running out of time. I'm sorry to cut you off. Maybe we can talk about a little bit more in details in our next segment. This is Dr. Vu. Our show is America's Healthcare Crisis. This is our 40th production, and we have been talking about the quality issue in dermatology with Dr. Ross Bright and Dr. James Arnold. We have been mentioning a few common skin conditions that they have encountered, and I'd like to invite you to watch the second segment where we will continue our discussion and maybe talk about some other aspects of practice of dermatology. I'm Dr. Hung Vu. Our show is America's Healthcare Crisis. Thank you for watching. Good night.
Do you love someone? Have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one now that I am here.